Hello and welcome. My name is Danish Bhatti. It gives me great pleasure to come and present to you guys my experience of diagnosing and a little bit on treatment of focal dystonias. So my name is Danish Bhatti. I'm currently an associate professor and education chair for neurology at University of Central Florida College of Medicine. And I used to be for many, many years at University of Nebraska Medical Center where I did a lot of this work. So I want to acknowledge a lot of my education and training and work that happened over there. And I'm delighted to present to you about focal dystonias. So I'm calling this experiential learning. It will probably be mostly, learning around specific concepts, some patient examples, some case-based learning, and hopefully not a traditional, typical, boring lecture. So I hope you enjoy it and you find some of these case example very useful. I do a lot of online education. I run an online mini fellowship in movement disorders, which is a 6 months online training program globally for neurologists and neurosurgeons and PMR and psychiatry graduates. And it's done once a year. I also have a lot of online courses and also run a very busy YouTube channel. So you can find me there too. So let's talk about dystonias. And dystonia is defined in the simplest term as a sustained muscle contraction with posturing, with or without tremor. But some of these terms need to be defined a little better. What exactly do we mean by posturing? And posturing of dystonia is any abnormal tilt or twist that is actually not fixed. So fixed dystonia paradoxically are psychogenic until proven otherwise, or it may be that they're contracture and spasticity and so on. And dystonia is a dynamic abnormal posturing which comes and goes, which fluctuates based on the emotional state of the patient, based on patient's activity, involvement, engagement, and so on. And similarly, a sustained muscle contraction is doesn't have to be sustained for minutes or hours. And as I said, it's a dynamic movement, so the posturing comes and goes. So sustain is defined as anything which is more than 200 millisecond electrophysiologically. Less than 200 millisecond will be called myoclonus. But there is definitely some confusion with something which is called clonus, which is a sustained muscle contraction, but is of muscular origin and is separate from what we typically call dystonia, which is a brain origin. So there are some confusing issues or scenarios sometimes in a patient where it looks like there's pulling, there's posturing, but is not obvious that if it's dystonia or not. And then the last thing to throw a little bit more confusion into the whole picture is that sometimes patient can have an intermittent pulling, which present as a tremor or more accurately pseudo tremor, sometimes called dystonic tremor, but may not have an obvious posturing or may not have posturing during your examination of the patient. And that also makes it a little difficult to diagnose. So we'll go through this a little bit. This is one of my patient who had more of a sustained posturing, which started as a dystonia, as a cervical dystonia in Parkinson's disease, but eventually became more of a sustained posturing due to curvature of the spine and probably some contractions or contracture that develop. So just to highlight the challenge of diagnosing a dystonia. But here's a picture from the internet of something which is more obviously dystonia. And here you're seeing platysma activation with the thin lines of platysma contraction visible in the neck. And along with the pulling of the lower lip, as you can see, there is these folds around the corner of the mouth. Sometimes we call them infralabial fold. My mentor used to call them the Pinocchio sign or a happy or puppet sign, where there are these lines of a moving chin that were used in the puppets to speak. And there's also deep nasolabial fold around the nose and even some pulling on the upper part of the nose, medial to the eyelid. And that is all a sustained pulling and tightness of the muscles of the lower face, moving all the way or pulling all the way up into the middle face. And that is, that is a dystonia, by definition, because of the sustained contraction. Now, it doesn't have to be present for too long. It may come and go. It may be only present for a few seconds at a time. But as long as the individual muscle contraction is longer than 200 millisecond, then this will qualify as a dystonia, in contrast to myoclonus when these contractions only happen less than 200 millisecond of the time. But this platysma dystonia is a very common dystonia, is often associated with cervical dystonia, is often missed. Now, if I read too much into this picture, you can see the patient has a head leaning downward into the left, and that may be an associated cervical dystonia, but platysma itself can cause enterocollis. So sometimes an enterocollis or interior bending of the head is seen just because of the platysma activation itself, with or without any of the SCM or sternocleidomastoid involvement. But dystonias can present in many, many subtle ways, especially these focal dystonias. So you can have a foot dragging as the only presentation of dystonia, which is a plantar flexion dystonia, very common in Parkinson's disease. Tiptoeing or in-toeing ambulation, again, part of the foot dragging. Muscle spasm are usually not dystonia, especially if they're painful. So here's a pro tip for you to remember that dystonias are never painful, with the only exception being cervical dystonia, which has a neck pain, but usually not a muscle spasm pain with it. So any muscle spasm that is painful is highly unlikely to be dystonia. The dystonia may complain of stiffness, such as in the leg or in the neck. Excessive eye closure or blinking may be a focal eyelid dystonia called blepharospasm. There may be uncontrollable movement, sometimes defined as shaking. So shaking is used very broadly for any jerky, twitchy movement which is repetitive of hand or face or leg, and that may actually be a dystonia. And inability to use the hand, for example, hand cramps, as seen with the writer's cramp. Voice abnormality, voice dystonia, or laryngeal dystonia is often underdiagnosed. And the tremor, as I said, can present as dystonia. So here's two pictures of patients with foot dystonia, which are complaining of in-toeing or dragging of the feet. Here are some other examples. On the top right is a jaw dystonia with a lateral pulling of the jaw. If you look at the midline of the teeth on the top and the midline of the teeth on the bottom, they're misaligned. And there is also some protrusion of the jaw where the lower teeth are at or in front of the upper teeth line, which is unusual. They should be behind the upper teeth line. So there's a protrusion of the jaw as well as a deviation to the right. So some form of a jaw opening dystonia or a mixed jaw opening and closing dystonia. On the top left on the screen is the blepharospasm example with some lower face involvement. You can see some deep nasolabial fold worse on the left side of the patient, and also some mentalis fold on below the lower lip, and some pulling in or flattening of the lip, which is also often a sign of a perioral dystonia. And there is also frontalis creases, which may or may not be dystonic, may be a attempt of the patient to try to open the eyes. And the picture, is overexposed. That means that there's a bright light on the face of the patient that might be triggering this facial dystonia. So it will not just be blepharospasm, but upper and lower face both are involved. And in the top left, the bottom left, is toe curling dystonia, which is again a very, very common dystonia in Parkinson's disease, but can be seen in young onset dystonias, including genetic dystonias like Oppenheimer dystonias. Jaw opening dystonias is often underdiagnosed, often missed, even by dentists, other people who see patients with jaw problem. And they could be jaw opening dystonia where they have trouble closing their mouth or they have trouble speaking. And there may be jaw clenching dystonia where they're speaking to their mouth and they look as if they're angry and upset all the time. And oftentimes they have associated jaw pains, they have denture abnormalities. The jaw closing dystonia can cause teeth to break. They could be that powerful. Masseter by in per square inch is the strongest muscle of the body for its size, and that's why it can create a lot of bone breaking. It can actually break your mandible because of the jaw dystonia. That it can be so powerful. Usually, the dystonia or dystonic muscle itself or spasm is not painful, as I mentioned earlier. And then, of course, there are these dystonias which are called task-specific dystonias. Any highly learned or over-specific task can lead to a task-specific dystonia, where the dystonia or abnormal pulling of the muscle or posturing is only seen during the task. And here are some examples. So a patient playing piano having piano finger dystonia in the hand and of the piano players, and can lead to twitching and jerking and can cause posturing. And here you can see abnormal bending of the third and fourth finger, and the fifth finger is lifted up, which may be actually a dystonic pulling. There's also, violin player. There's a flutist dystonia on the bottom right, also called embouchure dystonia. And you can see even platysma activation, perioral, mentalis fold of the mentalis muscle, infralabial fold, the puppet sign that I mentioned earlier. And then, of course, on the bottom left is the flutist dystonia, where their fifth finger is being pulling up and making it difficult for them to press on the keys. Here is an example of blepharospasm to show you how subtle it might
Medical
look.
record number
You
is
can see that the
24936.
patient just seemed to have excessive blinking,
Today is
and it may
November
be that the
11th,
lights are too bright, and that may be the often the
2022.
only
Can you
visible
hear me?
feature. But here you can see deep nasolabial fold, infralabial fold, mentalis pulling, and there is also some
Can you say today is
corrugator
a sunny day
pulling
in Omaha?
that you can see.
Today
And
is a
as the
sunny
patients
day in
speak,
Omaha.
you notice the jaw dystonia. See that how the
Can
jaw
you
is
say
pulled up,
today is
and
a
she speaks.
sunny
And let me
day
get
in
you the
Omaha?
sound and see if you can
Today is
hear it,
11th,
and see her
2022.
speak and
And
see
so
how
can you
her
just look into
sound
the camera
or
for
speech
me?
sound difficult.
Can you say today is a sunny day in Omaha? Today is a sunny day in Omaha.
So sound was actually not too bad, but you can see the excessive pulling on the lower face as she tried to speak. And there is an association of both upper and lower face dystonia with or without jaw dystonia. Because the voice sounded normal to me, I'm not sure if the jaw is definitely involved, but that will be something to also evaluate on her in a longer visit. Here's another useful pro tip that any isolated head tremor, especially if it's longer than 3 years, is cervical dystonia until proven otherwise. Here is an example of one of the bust of Alexander the Great, and all of his bust has his head tilted, and this will be a dystonic posturing where the chin is, the head is tilted to the left and pulled up and slightly leaned to the left, which is a cervical dystonia with left laterocollis, left torticollis, and postericollis. Very typical involvement in a cervical dystonia, actually, and likely traumatic given his life of actively fighting and training. Here is an isolated head tremor. You can see the tremor is side to side, what we call a no tremor. Usually, the sonic tremor is mixed. So, this is a short video, so it may be that the tremor she has changes from a no tremor to a yes or a mixed tremor. And then the if you pay attention to the tremor, you'll see the tremor has some pauses, what we call vex and wanes. So it's not constantly regularly present. It just comes and goes or stops and vex and wane, and that's typical. And also has a jerky feature to it, and you can also see the deep infralabial folds on her, the puppet sign. You can also see some mentalis activation. And then it may be that the camera angle, but you feel as if her right side is leaning down. So the right eye is lower, or the distance between right ear and the shoulder is less than the other. And then the jerk seems to be towards the right side. So right laterocollis with the right torticollis will be the concern for dystonia in her, although this video is not good in terms of giving her posture and is focused more on showing you that isolated jerky head tremor of cervical dystonia. The tremor is present in 60 to 70% of the patients. Neck pain is seen in 60 to 70% of the patient. As I said, the only dystonia that is known to have associated pain with it frequently is
Can you
cervical
just
dystonia.
let me
All other dystonias
look at
should
your
have no pain. Patient also
neck
seems to have his
cavity?
eyes
Your head
closed,
to one
raising
side or on
concern
the other?
for blepharospasm, although this is not evaluation for it. You see a jerky tremor that is
Your head
changing.
to the
It's
other
both
side?
mixed side to side, and a yes tremor and a no tremor mixed in based on where the head is
Whose side do
positioned.
you have
And
then?
you can see the tremor is
Huh?
jerky, irregular,
I have no
and
pain.
posturing is not
I
very
mean, just,
definable, although
it's
there is a
tight,
right
it's
lean which is
just
persistent of the top of his head,
passing,
but it
basically,
goes
just
from a
passing.
right or left torticollis because patient is trying to find a comfortable position,
And then
and the video is not trying to
in
assess
the
the actual
eyes,
posture, but to highlight the tremor
so it's like I got
in
two
this
things
particular
going on at the
patient.
same time.
Moving on, and I wanted to show you an example of what we call dystonic tremor. This patient actually has some posturing, so it might be a little easier to know. And here's a pro tip for you to remember that by definition, any tremor in a limb or a part of the body which has underlying dystonia is dystonic tremor by definition. So they have made it easy for us. The more challenge is when there is a tremor without any clear dystonic posturing. But let's look at this patient. So classic features of dystonic tremors that I will
This
define
is
you.
Mr. U.
As he's sitting, resting there comfortably, you see no dystonic posturing and you see no tremor. And then the patient is asked to raise his hands up. And as you see that as the hands go up in front of him, a tremor develops, which is mostly at the elbow, is and somewhat at the wrist. It's irregular, jerky, it waxes and wanes or comes and goes and stop. There is slight flexion at the wrist and downward pulling. The tremor changed as the hand position changed, and actually tremor has now disappeared. Although you can see a slight in the finger and slight bending of the finger and the wrist as compared to the other side. but the tremor is remarkably better in some position and comes back in other position for the elbow. And this feature is very typical as you resist the dystonic muscle. So to give you an example, if you are looking at wrist dystonia and the dystonia is pulling the hand down, if you try to lift the hand up, then the muscle you're fighting against the dystonic muscle, it will create increase in tremor as you try to go up. But if you listen to the muscle and go back down and go all the way in, the tremor may disappear. And the point where the tremor disappears as you go down or reappears as you come up is called the neutral point, or the point where the dystonic muscle feels happy. And it's often we try to find out during evaluation, patient clearly has dystonic posturing with the wrist bend, fingers bent, one finger more than the other as compared to the other side. But right now, in this neutral position, he doesn't have much of a tremor. Now, the tremor was at the elbow, and it may be that if he bends his hand, the tremor will show up. The tremor was at the wrist, so if he lifts his hand up, the tremor may show up. If we guess based on the dystonic posturing, and let's see if that is the case, and that is the case. And now patient has again a pronation supination component to this elbow flexion tremor, and let's see if we have the video of the patient's hand close to him. But the tremor classically is starts and stop, wax and wane, gets better in some position, changes direction, is irregular, jerky, and slow, and has neutral points for many of these tremors. And these are three different types of tremors we're talking about. There is the wrist flexion tremor, there's the elbow flexion tremor, there's a finger tremor. And here we'll see that the elbow flexion tremor might pick up. Again, there is asymmetry between the two hands. The right hand, you can see the fifth finger being pulled out, slightly bent, the wrist being excessively flexed as compared to the other side. The thumb has been pulled in or flexed, and the tremor comes and goes on certain position. So how do we define these dystonias? There's many ways to classify or label them. Two common ways is to label them based on age of onset and body distribution. Both of them are part of the axis one of naming classification of dystonias. Axis two is the etiology, axis one is the clinical characteristics, and two of the characteristics that we use age. So we define in these new definition, we have set timelines for these birth to 2 years in infancy, childhood, adolescent, early adulthood, and late adulthood. And this is the onset of when the dystonic abnormality started based on patient's recall or examination. But more commonly, we just label the dystonias based on body distribution. So focal dystonia, segmental, multifocal, generalized, and hemidystonias. And what's the definition? Focal dystonias are one that involve only one body part. So cervical, facial, handwriting, upper face, lower face, sometimes separately, such as jaw, or eyelid, or face, or perioral. Segmental is when two or more contiguous body parts are involved, so face and neck involvement, upper or lower face involvement, sometimes if it's blepharospasm and facial, or face or jaw involvement, upper limb with truncal involvement, or shoulder, neck, and upper limb involvement. While multifocal dystonia will be when there is two or more non-contiguous body part. When whole of one side is involved, that's hemidystonia, and when one or both legs with trunk or any other body part is involved, then that's a generalized dystonia. These are the definitions of how we call them: focal, segmental, multifocal, hemi, or generalized dystonia, and it's the most common terminology used. This was the old classification, which has now become only a small part of the whole XS1 classification. So, full classification or full naming will not be complete without other components like age of onset. Then there is dystonia seen with other features present or other situations present. So most common classification will be dystonia with Parkinson's. Now, Parkinson's disease can cause dystonia, which is considered secondary dystonia in Parkinson's disease. But there are syndromes where there is co-occurrence of dystonia and Parkinsonism, not likely from each other, but from something else common. So one common example will be just dopamine responsive dystonia has features of Parkinsonism. This is DYT3. And DYT5 is DRD, and DYT3 is also dystonia and Parkinsonism. While Wilson's disease can have both dystonia and Parkinsonism, and other inherited Parkinsonisms, such as PARC5 and PARC3, may have dystonia with it, and those are the dystonia Parkinsonism syndrome. Similarly, there's myoclonus with dystonia syndromes, DYT11 and DYT13, 11 being the most common myoclonus dystonia syndrome. And then there are dystonias which are genetic themselves. As I mentioned, the DYT classification. DYT1 is the classic Oppenheimer dystonia, which is early onset, limb onset, usually lower limb, and then secondary, and then gradual generalization over a few years of dystonia without anything else, no Parkinsonism and nothing else, so on and so forth. Similarly, DYT6 is isolated laryngeal dystonia, and then some other syndromes, and then, as you know, many other diseases like Huntington's and neurocancercytosis, so on and so forth, can also give dystonias. DARPLA, dentatorubropellidoleukine atrophy, and so on. And those are called dystonia syndromes. And then there are, all these classifications that I mentioned. So dystonia itself is a phenomenology. It's an observation of a behavior, and what is causing it may be primary idiopathic focal dystonia of no other cause. It may be a task-specific dystonia, or it may be dystonia due to Parkinson's disease, or a primary genetic dystonia, or a dystonia syndrome, dystonia and other inherited disorders, as I mentioned previously. Here is another example of a generalized dystonia or truncal and leg involvement. So let me play the first video before treatment. And instructions are in Urdu. It's from Pakistan. So I will block the video, but I'll show you the jerk and pulling. And this is an example of a very dramatic example of a psychogenic dystonia. Now, psychogenic dystonia is not a diagnosis of exclusion, because many times you don't find a cause for dystonia. So it's not that you can say, oh, I don't have an explanation for why this patient has a dystonia, so it has to be a psychogenic dystonia. Psychogenic dystonia is a positive diagnosis. So you have to have features such as distractibility, such as entrainment, such as incongruence, and so on and so forth. There is actually a beautiful book on psychogenic movement disorder by Dr. Mark Hallett, which has a chapter where he describes 17 observations, and often experts want to see 4 or more of those 17 observations in history, examination, and treatment patterns for us to positively diagnose someone as a psychogenic dystonia. And if you do, then even such dramatic patient can respond just to psychotherapy. So this is him 3 months after psychotherapy for this dystonia. And now you can see that there is significant improvement. Patient does have a feeling of Parkinsonism. I don't know if it's because of underlying depression or patient is on dopamine blockers. I believe the patient was taken off of all antipsychotic, and this was just psychotherapy alone. But this video was sent to me remotely. I haven't seen the patient in person. I saw him in between the 2 videos, but one video was before I saw him and one was afterwards. And then there are these task-specific dystonia. One of the most specific dystonia will be the writer's cramp. And what I want to highlight here is that in a task-specific dystonia, the dystonia is usually only seen during task. Now, once the task dystonia has been present for a long time, you can start seeing some of the dystonic features starting to spill over in other tasks and other general actions. But initially, in a task-specific dystonia, patient is completely normal in between tasks. And it is the only that specific task that will give dystonia. So a piano player's dystonia or a writer's dystonia only seen during writing, should not be seen in typing or cooking or doing anything else with the hand. So here, look at this patient. Patient has minimal tremor, some finger pulling when he has his hands up, some excessive flexion at the metacarpopharyngeal joint, but not much else. That was a minimal thing, could be easily missed if we don't point it out, and is debatable. You could debate if there is a finger scooping on the right hand, especially the fifth finger, or not. And now I ask him to make the hand as if he's holding a pen and trying to write to see if I can bring out some of the dystonic features and elements. And sometimes you can, but a lot of time you have to have a pen and you have to be actually writing to bring out that. And I can see a little bit of a jerk, but not a lot. But now, as soon as he has the pen and try to write, you can see that there's these jerks that happens in his hand. There is this excessive grip on the pen that you can see as blanching of the knuckles. So knuckles are the pen grip is so tight to try to hold it from shaking. Then you can see that there's a redness of the fingers and the blanching of the knuckles, which is often seen. There's excessive extension. Now this may be compensatory because 90% of the wrist, 90% of the tasks for dystonia of writing is actually wrist flexion. So wrist extension is 10% of the dystonic and is usually compensatory, but you can also see excessive supination, which again may be compensatory because 90% of dystonias in task specific writing is pronation, excessive pronation. So extension and supination is 10% of dystonias and usually compensatory because we see it more often than 10%. And it's very challenging to figure out, to be honest, but you can see the jerks. And if we go on to such as spirals, for example, you might see some of that jerking much better.
Sign as if you're
And
John Doe.
you can see that as he starts with the spiral, you see some of the jerks, but then as he goes around and goes to a larger circle, the jerks actually improve. And part of the reason is that this is not how he writes, right? His hand is lifted up off the paper, and this is not a normal writing position, and that is enough to stop the dystonia. So just changing the grip on the pen, just changing the position how you write, sometimes the dystonia of handwriting is only seen when you're writing sitting and may go away when you write standing. That's how sensitive to the position the dystonia can be, and sometimes you only see it in specific writing posture and not other. And here I'm asking him to write or sign again with a different grip of the pen to see if that improves his signature and reduces some of the dystonia, and if the patient feels better with less cramping in his hand in this dystonia. So general guiding principles on how you approach on treatment of these dystonias. Of course, you want to identify any treatable cause, any toxins, any immune deficiencies, inflammatory illnesses, and so on and so forth. You want to educate the patient and family about genetic dystonias with genetic counseling and address the comorbidities. The therapy is symptomatic because dystonia happens due to reorganization of the uh, cellular architecture in the brain, new networks, and that is not something that we can correct right now. But we can suppress the dystonia, or dystonic cramp, or jerk, or pulling and pain based on different therapies. You also can encourage them to discover and use their sensory tricks. Sensory trick is something that will hide or mask their dystonia. For example, if someone has a dystonic head tremor, touching their chin may be enough to stop or suppress their tremor. Just touching. It doesn't have to be pressed or strongly held. Though, so if you have to really hold your head from shaking, that is not a sensory trick. But if you just touch your head on the back and stop your head shaking, then that is a sensory trick. And then, of course, physical therapy is often very helpful. We do levodopa trial because many dystonias are dopamine responsive, not only DRD, dopamine responsive dystonia is genetic DYT5, but other generalized dystonia are often levodopa responsive. In focal dystonias, levodopa response is uncommon, and a levodopa trial can be skipped, but in a generalized dystonia, it's very common, or segmental or hemidystonia, so it's worth trying. And then surgical therapies and botulinum toxin. For a focal dystonia, the current consensus is that the treatment of choice for symptomatic treatment of focal dystonia is botulinum toxin therapy. And let me see if I can show you a couple of examples. But here's an approach in a focal dystonia. You can jump right to botulinum toxin treatment and that will be fine. That actually is a recommendation. Or you can try oral medications first. Physical therapy is often done in conjunction with botulinum toxin therapy. There are enough studies to show that physical therapy improves output from botulinum toxin. So BT alone or BT with physical therapy is superior to BT alone. And then there is these new studies that are looking at transcranial magnetic stimulation and transcranial Doppler and direct current stimulation, DC stimulation, and so on and so forth may be helpful. In generalized dystonia, the treatment of choice is oral medication. You may do Botox for some parts of the generalized dystonia if they're really bad, such as legs or neck or trunk. But usually, generalized dystonia, you cannot inject all the areas involved. So, oral medications play an important role, and levodopa trial might be the first thing to do. And then for failed focal or generalized dystonia, deep brain stimulation or other surgical therapies are indicated. In focal dystonias, it is very well established for cervical dystonia and not so well established for other focal dystonias, although there are some case reports of all types of focal dystonias, but it is FDA exempted for generalized dystonia and has a very robust evidence for significant benefit in generalized dystonia, and so on and so forth. So let's look at some of the rehab principles of treatment. Here's the study I mentioned. BT is useful. So you could do movement practices to try to retrain them, either retrain their brain or retrain them to do the task in a different way. I have seen patients who developing writer's cramp in one hand learn to write with other hand, but unfortunately, I've seen cases where after 10, 15 years of using the other hand, the dystonia also started in the other hand. Maybe they had that tendency in the brain now to develop it. You can also do task-specific motor training to learn to play the guitar in a different way, learn to play or do the task in a different way. I gave the example of handwriting. There has been some mixed studies on training with constraints. So constraint alone without training has not any robust evidence. So there has been, for example, studies doing wrist splints or a hand splint in writer's cramp for a few weeks and then training afterwards, and that did not show any benefit. So full constraint, but a partial it is not beneficial, but a partial constraint with training might be superior in terms of relearning or getting the task. And then you may even pair it up with botulinum toxin injection to really make it more effective. But I think the sad part about botulinum toxin, about dystonia in general, is that it learns to spread or adopt. So, for example, if we have cervical dystonia and we resect that muscle that is dystonic, the dystonia is spread into an adjacent muscle. So because you start using that other muscle, right? So if you stop using that muscle and start using something else, then it's a repetitive use of the muscle that can lead into then dystonia spreading to that muscle. You can do sensory reorganization, as I mentioned earlier, including wrist splints and restraints that I mentioned. And then one important thing that I noticed looking at the rehab literature was that the standard therapy that we use for typical rehab or therapy is likely not high dose enough to be effective in dystonia. So it is compared against animal models. So functional arm training in OT, for example, is 32 reps and is done only half of the time, or functional leg training is done more commonly 84% of the time, but at 357 sessions steps per session. But in contrast, the animal studies that showed benefit of these typically have much higher reps, so more than 300 reps for animals, multiple sessions during the day, more than 1,000 steps for recovering animal that get improvement in dystonia. So it may be that the dystonia therapy needs to be modified and made more intense in terms of getting the results from that therapy based on the animal studies. Botulinum toxin injections I mentioned. So here's a patient with enterocollis, and I am
Turn your head
doing
that way.
cervical
Very
injections.
good.
I use EMG guidance to do
Now put
my
your left hand.
muscle injections. I do not use EMG guidance for subcutaneous or gland injections, but for muscle injections, I always use EMG guidance, even for jaw injections, uh, just because it gives you more accuracy of being right in the muscles. Some of the muscles are so thin or flat that it's easy to go through them and go beyond. But it also changes from center to center. That's how I was trained and how I'm comfortable. But on EMG, you can hear the dystonic muscle with or without activation. So that's another feature of a dystonic muscle, that it is active at rest. So even when you are asking the patient to just completely relax, the dystonic muscle is usually active. Not always, but usually. Here is a EMG sound from SCM injection
Against your chin.
for a
Very good.
sternocleidomastoid
Now
injection.
push your
And
hand
my
against
approach in
yourself.
SCM
Try to look
injection
that
or
way and
most
push your
injection is
hand
to
this way.
follow the muscle. So
Very
you will see
good.
that I'm not going parallel into the muscle, but following along the path of the muscle, especially because SCM is very thin and flat muscle,
There's
and
a
it's easy
pull.
to go across it. And you can hear the EMG signal, almost like a machine gun firing. Let me show you to again. And you can comfortably know that you are in
Turn
the
your head
muscle.
that way.
Surgeries has been another mainstay, actually, way before any other treatment started, way before botulinum toxin oral medication became popular. And we figured out that this globus pallidus interna is, if you lesion it, then that can overcome a lot of these dystonic circuits. And you would put a wire in into GPI and you can burn it. And pallidotomy was one of the early treatments. But later on, we learned all the side effects. More treatments came out, like botulinum toxin injections. And now there has been resurgence of surgical therapy for these treatments, just because surgeries are becoming easier and we have the deep brain stimulation. We put the lead in and leave it there and don't burn it, but you can constantly stimulate it and you don't even have to put a lead in with newer techniques like focus ultrasound. And then, as I said, we're also looking at doing the transcranial stimulation, magnetic or Doppler, but they are not powerful enough to get all the way down into here, although there is some research going on with powerful magnets to see if we can create the effects of our deep brain stimulation through scalp stimulation without having to go all the way in. But here's a patient. It is a
Pretty
patient with
good too.
Parkinson's disease. So in the off state with the
Okay.
stimulator, so DBS has been placed. In the off state, besides the tremor, you can notice the dystonia. Patient has severe truncal dystonia forward, which is called camptocormia. There's likely some cervical dystonia, and there is some leaning of the trunk to the left, which is also called Pisa syndrome because of the leaning of the trunk. And then there is some dystonic posturing even of the hands and elbows with the DBS off. And when you turn the DBS on, you not only get the tremor control, you also get the dystonia control with improvement in truncal posturing, in arms posturing, and in the head and neck posturing. So let's see what happens when the DBS is turned back on this
She's had
patient.
a regular release, a time release, and I gave her half regular release around 9:30 or so.
How are
And
you
here you
feeling?
can see that the patient is so much better. There might be still some enterocolus, and there might still be some right bending of the head, some activation of the neck muscles, but is definitely much better than what the patient was. And the targets for DBS in Parkinson's disease, not always globus pallidus, but also subthalamic nucleus. And there was a recent study that were 3 years ago that was published that showed that SDN stimulation might be equally effective in treatment of dystonias, even generalized dystonia unrelated to Parkinson's disease. We knew that in Parkinson's you can treat dystonia with STN stimulation, but even without Parkinson's, STN stimulation might be fine in treating dystonias. And then, as I mentioned earlier, that for focal dystonia, cervical dystonia has the best evidence. Very strong. A paper came out from Germany, 174 patients with focal cervical dystonia who had DBS done with 70% plus response rate, and very effective benefit in this. So with that,
Okay.
let me conclude here. As I mentioned, I do have some online training and courses that you can check out on Merit Academy. And then I have a YouTube channel. Actually, I have some botulinum toxin injections from Pakistan on my YouTube channel. And I also have lectures on cervical dystonia and some other lectures on mechanism of action of botulinum toxin and Botox injections and so on my YouTube channel. So if you search me, and then in my channel, you can search for botulinum toxin or dystonia, and you might find some of the interesting videos that you might find useful for your practice. Otherwise, you can reach out to me at danish.bahati@ucf.edu, and I'll be happy to answer any questions, collaborate with you, direct you to any useful resources that you might be looking for. And you can also find me and connect with me on LinkedIn. Again, Danish Bhatti if you search on LinkedIn, or you will find me, and I'll be happy to connect with you and answer any questions you might have. And let me stop here and get it over back to our moderator.